Two, one. Please start, sir. We are live.
Very good evening. I take this opportunity on behalf of Bayer Pharmaceutical Oncology Division to welcome all the audience, doctors who are presented in the meeting, and also our eminent speakers. So, without delaying any time, I would like to go into the meeting. So, I would like to welcome Dr. Varun Rajan, sir, consultant medical oncologist, Medical Trust Hospital, Kochi. So, sir will be talking on reaching new heights in metastatic hormone-receptive prostate cancer, Arasens trial. So, over to you, sir.
Yeah, I'll be trying to. So, is my screen visible to you?
Yeah, screen is visible, sir.
Yeah. Yeah, slides are moving, right?
Yes, moving, sir.
Yeah. All right. And so good evening to all, and thank you, Bayer, for arranging this meeting, and thank you for the opportunity. So I'll be mainly actually focusing on the newer advancement in metastatic hormone-sensitive prostate cancer care. So it is my disclosure. The slides were prepared actually from the Bayer scientific team. And so we all know what is the current therapeutic landscape of a prostate cancer and also actually natural course of the disease. So in the case of a localized or locally advanced prostate cancer, usually after the local treatment, the patient may fail after some point of time that we call it as biochemical recurrence. And then again, it can be a non-metastatic CRPC or a progressive metastatic HSPC so anyway, actually the backbone of the treatment is ADT that we all know, or it may be a case of newly diagnosed metastatic HSPC. So all this patient will progress to metastatic CRPC after some point of time, and eventually the patient will progress actually it will lead to a terminal disease. And the treatment of the metastatic CRPC, the overall survival improvement is mainly only in the tune of the 2.5 to 4.5 months. So the opportunity to delay the development of metastatic CRPC is the key player here, and how to delay actually the natural course, or how to delay the development of a metastatic CRPC is what we are going to discuss here. We all know the data from the Stampede trial, that is mainly when the patients were treated with the nirogacestat and ADT. So it significantly improved the failure-free survival and overall survival. And again, we can now do much better with the newer molecules. So again, so actually in the Stampede trial, we know actually the patients were divided into oligomets and high volume metastasis, and we can see in the case of actually oligomets where the prostate RT was also given, and it improved both the failure-free survival and overall survival. But in the case of a high volume disease with more than 4 sites of skeletal metastasis, actually the benefit was null or just marginal. So if you see all the trials in metastatics setting, that is starting from the initial GETUC trial, Charter trial, and Stampede trial, which all investigated the role of docetaxel, and later it became the standard of care in metastatic prostate cancer. Then Latitude trial, about the abiraterone and prednisolone. Then Arches trial about enzalutamide, Titan trial about apalutamide, and Enzamet trial. Then came the Peace-1 trial, again abiraterone and the prednisolone. Then Addison's trial, the latest trial. It all shows that when we are adding the agents to the ADT, it improves the survival, and mainly our focus was to delay the progression to ACRPC. So how do we choose is the biggest question here. So if you see the charter trial, that is actually the role of docetaxel in metastatic the hormone sensitive prostate cancer, you can see that mainly actually it created a difference in the case of high volume disease, that we can see the hazard ratio was significant, that is 0.63 with a significant p-value, and the survival was improved by around 16.8 months, whereas in the case of a low volume disease there was no much improvement in the survival. And coming to the case of Latitude trial, where it was compared against the ADT, that is ADT plus abiraterone plus prednisolone. It was compared actually against the ADT alone. So so this you can see that actually here the comparator arm was only ADT. And the crossover was also less in this trial. So because at that time, actually much drugs were not approved in this setting, so most of and in the comparator or in the control arm, actually it was an undertreated arm, and you can see the results were very bad in those cohort, and the most of the patients were offered supportive care only after progression. So abiraterone was the first to show the hormone treatment can affect you and it can improve survival in Latitude trial. And but we all know the problems of abiraterone, particularly when we are using that in elderly, because we are using abiraterone along with steroid also. Even if we are reducing the dose of steroid to only 5 milligram per day, still it can have its own problems in the form of hypertension, hepatotoxicity, hypokalemia, cardiac disorders, fluid retention and its problems, osteoporosis, and the chance of fractures and cataracts. So these all are the problems of using abiraterone and steroids, particularly in elderly patients. And coming to another trial, Titan, where they investigated the role of apalutamide. Here also, apalutamide plus ADT was compared against ADT plus placebo, and you can see the actually the improvement in progression-free survival and overall survival. Hazard ratio was around 0.65, and all the all the difference were evident in the case of high risk population, particularly in those patients who had actually the high volume disease. Then coming to the enzalutamide trial, where they compared enzalutamide plus ADT, it was compared against the ADT plus NSAA, and it also showed that it improved survival, particularly in the case of high volume disease. So we all now practice combining therapy to improve the outcome, particularly in the case of the metastatic HSPC. And the piece one was the another study where we took actually the oligometastatic disease also. So mainly they included the patients with the de novo metastatic disease, and where they compared abiraterone as a standard of care versus standard of care plus the local RT. And so in this trial, they have used local RT to the oligometastatic disease, and we can see that actually in the PEACE trial also, where they investigated the ADT plus the DOSI plus abiraterone in those population, it yielded benefit in high volume disease. So this led to a confirmation that in high volume disease, you could improve outcome by adding abiraterone to docetaxel versus docetaxel alone. That is the use of triplet therapy in the other form. That is the PEACE 1 trial. But in low volume disease, it didn't seem to be as beneficial as we saw in the case of high volume disease. That is ADT plus DOSI plus abiraterone. So coming to the Addison's trial, so we all know it's a global RCT double-blinded trial. It was a phase 3 trial. They mainly included metastatic HSPC, the patients, and also they have stratified disease into M1A, M1B versus M1C. And in those patients, the triplet therapy were given, ADT plus nocitaxel, and in the experimental arm, they have used that darolutamide, that is 600 milligram twice daily, and in the control arm, it was ADT plus DOSI plus placebo. And actually 87%, that is nearly 90% of the patients received all 6 cycles of navcitaxel. So the tolerance and the compliance was good, and adverse events between the arms were almost identical. Even though actually it was a triplet regimen, the adverse effects were comparable between these two arms. And you can see that if you see the overall population, it significantly improved actually the overall survival when a triplet using ADT plus DOSI plus darolutamide was used in Addison's trial with a hazard ratio of 0.68. And particularly actually it yielded benefit in both high volume disease or high risk disease versus low risk disease. So that is the main difference of the Addison's trial and the PEACE-1 trial. It yielded benefit in both high risk and low risk disease. And if you see all the variables, all the subgroup analysis, like the time to CRPC or time to subsequent antineoplastic therapy or time to pain progression or time to first SSC, it all actually the use of the triplet using darolutamide, it improved the outcome with a significant actually with a statistically significant values. And again, another thing is, so our main aim, the focus was to delay the development of CRPC. And you can see that the undetectable PSA, it's another variable, or the time to PSA progression. So in the Addison study, actually more than 2/3 of the patient reached below 0.2 of the PSA in the oral study. And in those patients who had undetectable PSA at 36 weeks, they had an improved survival when compared to those patients who didn't achieve an undetectable PSA. And it was it is translating into improvement in oral survival also. And the drug darolutamide triplet achieved the long periods of no disease progression and also significant improvements to oral survival. You can see in those patients who were undetectable PSA, it translated to an improved oral survival. And again, the event-free probability was better. Particularly in those patients who had undetectable PSA with the use of the triplet therapy. So things to consider or how to decide between a doublet and triplet in a metastatic HSPC. We all know the patient is able to tolerate and accept the docetaxel or not, and to stratify the disease, whether it's a high volume disease or a low volume disease, and what is the likelihood of the hormone insensitivity clones in a metastatic disease, then age or the life expectancy of the patient, then hit hard and early that we usually counsel to this patient, because the prostate cancer will be the cause of death in those patients. Then another question is, will docetaxel be an obligation in the near future? And also much less effective post ARPA progression, and this all we have to be discussed, and the patient actually need to be informed of the options, whether to campaign with the drug darolutamide, or we have to go with the abiraterone as per the PEACE-1 trial, or we have to go with Addison's trial. These all we have to discuss, or we have to consider case by cases. Depends if, actually depending upon the risk of the disease or the volume of the disease and the performance status of the patient. Thank you.
Thank you, sir. Thank you for presenting Addison's trial, sir. Thank you, sir. Now I would like to welcome Dr. Rachan Shetty, AG Consultant Medical Oncologist, AG Hospital, Mangalore. So, sir will be talking on Aronaut evidence, advancing metastatic hormone-sensitive prostate cancer treatment, horizons, darolutamide without chemotherapy. Rachan, sir.
Hello.
Raj here.
Sir, I am I am sharing the screen, sir. Yes, sir.
Hello, Rajan. How are you?
Hi, Arun. Going on. I'm in the car. It's a little dark.
It's all right.
Sir, hope you can see my screen.
Yeah.
Yeah. Sir, I'll be taking your instructions, sir.
Yeah. Okay. So at the outset, I would like to thank organizers for arranging this meeting. So we're talking about whether we can give only androgen deprivation therapy with darolutamide without chemotherapy in this trial. So we'll start with this one. Second, next slide, please. The disclosure. Next slide, please.
Yes.
So, as we know, historically, androgen deprivation therapy alone was considered the standard treatment for metastatic hormone-sensitive prostate cancer. So, over the last 10 years, we have seen multiple landmark trials like Charted trial, Latitude trial. You are going to Arasens study. I think before that, there are a few studies. Please go back. I think it's not the same slide which was sent to me. Please go back. Please go back. Please go back. Go back. Go back. Go back. Go back. Go back. Go back.
Sir, this is a slide, sir.
Yeah, next slide. Next slide. Yeah, this is a slide. So multiple landmark trials have come. So we have Charted, Latitude, Stampede, Titan, Enzymet, where treatment intensification along with androgen depression therapy with treatment intensification has shown improved patient outcomes. And these studies establish combination therapy is the way to go. Despite these advances, many patients continue to receive androgen depression therapy alone. So many people, due to frailty reasons, multiple comorbidities, and most often, some are not really elderly people are not reluctant to undergo chemotherapy. So even though treatment intensification is the standard of care, many we are not able to give. This is an unmet need. So here comes the why this Aeronaut study was done. Next slide, please. So Arasens established, we have darolutamide. Arasens established ADT plus docetaxel as an effective treatment. Not every patient is an ideal candidate for this chemotherapy regimen. Many patients of prostate cancer are elderly, have multiple comorbidities, and simply prefer to avoid chemotherapy-related toxicities. And therefore, it remains an unmet need for a therapy that offers robust efficacy, maintains a favorable safety profile, and minimizes drug-to-drug interactions without requiring chemotherapy. Aeronaut was designed specifically to address this gap. And whether Aeronaut evaluates whether darolutamide can provide meaningful benefit with ADT alone. Now let's go to the study design. Next slide, please. Next slide. Yeah. Aeronaut is a randomized double-blind placebo-controlled phase 3 study involving 665 patients with metastatic hormone-sensitive prostate cancer. In this study, patients were randomized in a 2:1 ratio to receive darolutamide 600 mg twice a day versus plus androgen deprivation therapy or placebo plus androgen deprivation therapy. The primary endpoint was radiographic progression-free survival. For important secondary endpoints included overall survival, time to CRPC, and time to PSA progression, initiation of subsequent therapy, pain progression, and safety. Median follow-up at the primary analysis was 25 months. And this is a double-blind phase 3 trial with the clinically meaningful endpoints. Now let's go to the next slide, which is looking at patient baseline characteristics. So coming to this baseline demographics, it was evenly balanced between both the treatment groups. Median patient age was 70 years. Approximately 70% of the patient had a high volume disease and 70% presented with de novo metastatic disease. One third of the enrolled patients were Asians, including a substantial number from India, And these balanced baseline characteristics strengthen the validity of this study. Next slide. This is the slide which shows the geographic representation. As you can see, we have a significant Asian and Indian population. In India, about 60% of 60 patients were of Indian origin. So it holds relevance to our country. Next slide. Now coming to the primary endpoint. So the primary endpoint of this study was radiographic progression-free survival. So in this darolutamide plus ADT significantly reduced the risk of radiographic progression or death by 46% compared to ADT alone. The hazard ratio of 0.454 was highly significant, and with a p-value of less than 0.0001, this is significant. And at about 25 months of follow-up, median relapse, recurrence-free, progression-free survival have not reached in darolutamide arm, where it was 25 months in the placebo arm, which received only ADT. These findings demonstrate a substantial delay in disease progression. So the key point to remember is 46% reduction in risk of progression or death in patients not receiving chemotherapy along with ADT or ARPIs. Now coming to subgroup analysis, next slide. In this, as you can see, improvement in radiographic PFS, progression-free survival was remarkably consistent across all predefined subgroups. Patients benefited regardless of age, PSA level, ECOG performance status, disease volume, race, geographic region, or presence of visceral metastasis. Particularly noteworthy was the benefit observed in high volume and low volume disease, supporting the broad applicability of darolutamide. And and there is no obvious subgroup, as you can see, that has failed to benefit. Next slide. So beyond the primary endpoint, this arrow note also demonstrated improvement across multiple clinically important secondary outcomes. Darolutamide demonstrated favorable results across all major secondary endpoints. It significantly delayed PFS and delayed progression to metastatic CRPC, delayed PSA progression, postponed the need for subsequent systemic therapy, and reduced pain progression. Although overall survival data remains immature, the trend favored darolutamide since Aranote was powered for this progression-free survival rather than OS. Continued follow-up will probably provide more definitive survival data. So the benefits extends well beyond delayed radiographic progression. Next slide, please. So as you can see, delaying progression matters. Improving radiographic progression-free survival, darolutamide significantly delayed the progression to metastatic castration-resistant prostate cancer. The hazard ratio was 0.4, corresponding to a 60% reduction in the risk of progression to CRPC. And in this study, darolutamide significantly delayed pain progression with a hazard ratio of 0.72. So the pain is one of the most important symptoms which affects quality of life in metastatic prostate cancer. And delaying this pain progression allows patient to remain active and maintain independence and often postpone opioid use or palliative interventions. Now coming to the next slide, whether PSA response. So as we know, PSA is an indicator of treatment efficacy. And PSA response remains an important surrogate marker for treatment activity in metastatic hormone-sensitive prostate cancer. Darolutamide significantly delayed PSA progression with a hazard ratio of 0.31, representing nearly 70% reduction in risk. Moreover, at 63% receiving darolutamide achieved an undetectable PSA level below 0.2 nanogram per ml at some point during treatment, compared with only about 19% in the placebo arm. These findings indicate deep and durable suppression of disease activity. So deep PSA responses are generally associated with better long-term outcomes. Now coming to next slide. Now coming to this PSA responses in high and low volume disease. So this is, an important observation was that error note is that higher rates of undetectable PSA were achieved regardless of disease volume. Patients with high volume and low volume disease consistently demonstrated superior PSA responses with darolutamide compared with ADT. This reinforces the broad applicability of darolutamide across the spectrum of metastatic hormone-sensitive prostate cancers. So coming to next slide, whether subsequent life-prolonging therapy were required. So in this graph, I can see shows reduction in the need for later treatments. Fewer patients receiving darolutamide required subsequent life-prolonging therapies compared with placebo, suggests that disease control was maintained longer, delaying need for chemotherapy and other androgen receptor pathway inhibitors. So it reduces treatment-related toxicity and leads to fewer subsequent interventions. Coming to the overall safety profile, next slide. Despite a longer median treatment duration of over two years, darolutamide demonstrated an overall safety profile compared to placebo. Rates of treatment emergent adverse events, grade 3 or grade 4 toxicities were very similar between treatment groups. This favorable safety profile is one of the distinguishing characteristics of darolutamide among androgen receptor inhibitors. So longer treatment did not translate into higher toxicity. Now coming to the common adverse events. Next slide. So the common adverse events was generally low and balanced between the treatment groups. Events such as anemia, arthralgia, urinary tract infection, constipation, hypertension, hot flushes, fatigue and back pain occurred at similar frequencies. Importantly, there was no major increase in severe toxicities with darolutamide supporting its excellent tolerability profile. Some adverse events are particularly associated with androgen receptor inhibitors. So compared to next slide, androgen pathway associated adverse events. So these androgen pathway inhibitors have adverse events like hypertension, fatigue, cognitive impairment, falls, fractures, rash. These remain generally low and comparable between darolutamide and placebo. These favorable profile likely reflects darolutamide's minimal penetration across blood-brain barrier and relatively low potential for drug-to-drug interactions. As we know, most elderlies have diabetes, hypertension, around multiple drugs. Some ischemic heart disease, some are on anticoagulation, which really gets affected with the other drugs of this same class, making it and it remains an attractive option for an affordable elderly patients with multiple comorbidities. Next slide. This is health-related quality of life. So in this, patients experienced a meaningful delay of deterioration of health-related quality of life score by FACT-P total score. And compared to placebo, there was 5 months improvement in quality of life. Next slide. So to summarize this entire study, in this note demonstrated that darolutamide combined with the ADT significantly improved radiological progression-free survival in patients with the metastatic hormone-sensitive prostate cancer, and benefits were seen across secondary endpoints. That is delayed progression to CRPC, delayed PSA progression, delayed pain progression, reduced need for subsequent systemic therapy, deep PSA responses, and favorable safety profile, and the preservation of the quality of life. And this darolutamide plus androgen deprivation therapy is a compelling alternative for a chemotherapy-free option for an appropriate patients. Next slide. And to conclude, thank you for your attention. And this phase 3 evidence says that it's an effective chemotherapy-free treatment strategy for metastatic hormone-sensitive prostate cancer patients. This regimen demonstrated substantial efficacy, excellent tolerability, delayed disease progression, and meaningful quality of life benefits, and was consistent across patient subgroups. These findings have the potential to expand treatment options and support more individualized care for patients with metastatic hormone-sensitive prostate cancer. Hereby I conclude my talk and thanks the organizers again for this opportunity.
Thank you, sir. Thank you, Dr. Rachan Sethi, sir, for presenting around evidence. So now I would like to welcome Dr. P.S. Dattatreya, sir, Chief Medical Oncologist, Clinical Director, KIMS Hospital, Hyderabad. So, sir will be presenting real-world case study.
Thank you so much, Sandeep. And unfortunately, I am also stuck in the traffic. And so, therefore, from the car, I'll be talking. But I hope I am comfortably audible to all of you.
You are audible,
Yes,
sir.
yes.
Yeah. And after those two excellent presentations, which talk about the evidence behind why we choose darolutamide, I'm so thankful to both the two previous speakers for eminently bringing out the science behind the way we go about choosing these drugs. So now I thought I will talk about one of my cases where I had to use or I preferred or chose to use darolutamide.
Vinod, are you sharing the screen?
Yes, Sandeep, give me a minute. I'll share now.
Yeah. No problem. In the meantime, I can just start by telling that this was basically a 64 years old male with an excellent ECOG performance status of 0. The baseline PSA was 30.61, and that essentially made him to evaluate, and then he was found to have a de novo high volume metastatic hormone sensitive prostate cancer. So the
Sorry,
next
sir.
slide.
Sorry for, sir. Is it visible, sir? Screen?
Yes, I can visible the next slide. I can see it very well. So 64 years old male, good ECOG performance status, baseline PSA 30.61, no comorbid conditions, retired employee of SBI, physically pretty fit patient. Next, diagnosed to have de novo high volume metastatic hormone sensitive prostate cancer because the PSA being high, a PSMA PET CT was performed. The biopsy confirmed Gleason 4 plus 4 acinar adenocarcinoma of the prostate. Extensive skeletal metastasis, regional node involvement, increased PSMA expression in the prostate primary, in the regional nodes, and the bone metastasis. Next slide. So let me now go to the patient management. So this was CA prostate adenocarcinoma. Initially explained about surgical orchidectomy, was planned for the same in January 2023, but finally declined and chose medical orchidectomy with LHRH agonist. And he also gets along with the ADT 8 cycles of docetaxel, and treatment intensification to the ADT was docetaxel plus oral darolutamide. So he gets a triplet of ADT, LHRH agonist, intensification of the ADT with docetaxel and darolutamide. And of course, this is in line with the RSS trial, which was discussed so elegantly by the first speaker. The alternative option was to choose the triplet of ADT, abiraterone, prednisolone. Fortunately, he was able to understand the difference because he was well educated and wanted to be involved in the decision making. In June 2023, finally, darolutamide also was started. Next slide. And as you can see, the PSA dropped from 30.61 next to 0.08 in November 2023 next, and became 0.01 in December 2023. Can I have the next slide, dear? Yeah. The PSMA PETs in October 2023 showed improvement in all the metastatic sites. The next slide will show you the pictures showing the good improvement as compared to the baseline PSMA PET scan in January 2023. Next. And the next, we found the following improvements. Next slide. There was no PSMA expressing pelvic lymph node. Next. All the previous bone lesions, there was a reduction in the PSMA expression across all the skeletal sites. Next slide. The PSA dropped down to 0.04. Now that's a small mistake there in April and July also it's 0.027 and 0.024. So continues to come down and now it's as low as 0.024 in last month. But wanted to share, next slide, my treatment experience with darolutamide triplet. Very good response to 8 cycles of docetaxel, good tolerance, and did have fatigue, joint aches, and of course hair loss. But after the chemotherapy got over, these symptoms since then have resolved and continues to be on darolutamide from June 2023 all the way to December and now in July 2024 continues to be now on darolutamide.
Take two photos, okay? Two
Next
photos.
slide. Darolutamide full dose, very well tolerated. He continues to be on follow-up every 3 months, and the follow-up is timed along with his subcutaneous LHRH agonist, which was leuprolide. So, in conclusion, the Arasens triplet is effective, well tolerated triplet regimen benefiting this high volume metastatic hormone sensitive prostate cancer patient. Now, apart from the efficacy, is the excellent safety and the AE profile, which was so well brought out by both the previous two speakers. What's even more important is, of course, this patient did not have any comorbid conditions, but many of the elderly people would be having various comorbid conditions requiring multiple drugs like, say, cardiac medications, antihypertensives, thyroid, or diabetic medications. Polypharmacy for comorbid conditions, but this drug Daro has essentially nil or zero drug-drug interactions, limited DDI profile, and that makes it a preferred choice. I would just want to discuss two simple questions. So, should we limit the triplet only to patients having high volume metastatic hormone sensitive prostate cancer, or can I give the triplet to a low volume patient also? If you look at ASCO, ESMO, or the CSCO guidelines, the recommendation is strong, be it a triplet of darolutamide or a triplet involving abiraterone, the PEACE-1 regimen. In low volume metastatic hormone sensitive prostate cancer, the recommendation continues to be strong for a darolutamide triplet, but no recommendation for abiraterone. If you look at Daro, the triplet of ADT, docetaxel, and darolutamide, both the groups, be it high volume patient or low volume patient, there's a more than 30% reduction in the risk of death, which is consistent with the overall population. Most patients in Arasens had high volume disease, but even in the smaller low volume subgroup, the results showed a survival benefit. Certain patients with low volume MHSPC which are having some features which could clinically inform us that these have a higher chance of progression again benefit by early treatment intensification with daro ADT and docetaxel. So high volume or low volume metastatic hormone sensitive prostate cancer, all of them stand to benefit with this triplet with a more than 30% reduction in the risk of death, which means an advantage in overall survival. And that is what we as medical oncology colleagues would want to see in stage 4 patients. Lastly, next slide. How do I choose between the two triplet regimens without cost considerations? Now, ARASENS, as was rightly pointed out, is the only trial prospectively designed to provide clear and compelling evidence. The evidence is clear and compelling that the combination of Daro ADT docetaxel prolongs OS when compared to docetaxel ADT. Minimal additional adverse events, more than 30% reduction in the risk of death. On the other hand, PEACE-1 was an open label study. It looked at abiraterone ADT only in patients of de novo metastatic hormone sensitive prostate cancer. Arasens was both de novo and recurrent. Piece 1, the study design, did not originally include, but later got modified to add treatment with docetaxel. And so in this piece 1 docetaxel population, two-thirds of the patients had high volume disease. In Arasens, three-fourths, 77% had high volume disease. The piece 1 results in patients of high volume disease show the benefit of early treatment intensification. Agreed, but with abiraterone prednisolone, you also have higher and severe grade 3 hypertension and hepatotoxicity. So, of course, you need to watch out for blood pressure readings carefully and also look at LFTs when your patient is on abiraterone prednisolone with docetaxel ADT. We also know that when we put patients on abiraterone, you would want to frequently monitor for mineralocorticoid excess, for LFT alterations, and adrenocortical insufficiency. And then abiraterone prednisolone definitely has a drug-drug interactions. And so all these points will make us understand why we should choose darolutamide triplet over abiraterone triplet, especially with the fact that since most of these patients are elderly, therefore they would be on multiple drugs to treat their comorbid conditions. With that, I would like to conclude that the triplet of Daro, ADT, docetaxel becomes the preferred combination partner when rather than the abiraterone prednisolone with docetaxel ADT. Thank you so much, everybody.
Thank you so much, sir. It was an excellent presentation and very, very clearly explained the role of darolutamide. Thank you so much. Thank you so much for all the speakers, especially Dr. Varun Rajan and Dr. Rajan Shetty. It was a nice presentation. To be frank with you, as a Bayer, we strongly believe in sharing science. And today, I would really, from the bottom of the heart, I would like to thank all the three speakers. That is Dr. Varun Rajan, Dr. Rajan Shetty, as well as Dr. P.S. Dattatreya for helping us in sharing knowledge as well as science to entire audience. And I'm happy that we had a very fruitful discussion and fruitful understanding, especially on this today evening. And I request we will conclude the session, sir, with your permission.
Thank you. Thank you so much, dear. I learned a lot. Thank you so much.
Thanks.
Thank you.
Thank
Thank
you,
you
sir.
all.
Thank you, sir.
Thank you all. Now we can conclude the session. Can you, technical team, are you there?
Yes, sir. We
Yeah,
are
please close the
concluding the session now.
Yeah, thank you.
Thank you. Thank you all.